I'm Dr. Ganga, your nephrology educator at Prep Ladder. I'm here today to discuss about minimal change disease. So what is minimal change disease? Minimal change disease is also called as lipoid nephrosis or minimal lesion. It is called as lipoid nephrosis because patients with minimal change disease who are having nephrotic syndrome excrete lipid globules or fat globules in the urine. Hence, it is called as lipoid nephrosis. It's called as minimal lesion because there will be only subtle changes in the light microscopy and there is going to be effacement of podocytes seen in electron microscopy. So, in a patient with minimal change disease, if you see the light microscopy and immunofluorescence, it can be absolutely normal. Only in electron microscopy, you will find that there is effacement of podocytes indicating us to this diagnosis. In children, this is the most common cause of nephrotic syndrome, affecting 80% of children, and in adults with nephrotic syndrome, it is around 20% common. Now, the important thing about epidemiology of minimal change diseases, it shows seasonal changes with increases in winter and no much difference in summer. And also, among the difference among the sex, among children, the male children have more probability of acquiring the disease when compared to female. So coming about the sex difference, in children it is male and females have equal predisposition. So coming in children, male have more common disease when compared to females, whereas in adults, male and female have equal predisposition. Now coming to the etiology, it can be classified into idiopathic or primary, or the next one is secondary. Okay. Now among secondary, of course, there will be many causes. The major classifications are drugs, allergy and malignancy. Now among drugs, the important one is NSAID, which is phenoprofen. So this phenoprofen becomes important because the tendency of this to cause nephrotic syndrome, the reaction is idiosyncratic. That means the patient can be taking this chronically and after months patient can develop nephrotic syndrome. And there is associated renal dysfunction when this happens. This happens because the lesion is not just minimal change disease. It is minimal change disease plus acute interstitial nephritis. So this combination of lesion occurs when patient takes phenoprofen and develops nephrotic syndrome. The other drugs are interferon alpha, lithium. Lithium, we should know, more commonly causes chronic interstitial nephritis. This I have described in chapter of chronic interstitial nephritis. And other one is gold. Gold also, it is rare. It causes more commonly membranous nephropathy and less commonly minimal change disease. So NSAIDs and phenoprofen is a very important thing that you have to remember. Apart from this, allergies to maybe pollens, house dust, any immunization or poison oak. Next is malignancy. Malignancy, it is important to remember about one disease, that is Hodgkin's. What happens in Hodgkin's is, we know that Hodgkin's has RS cell, that is Reed-Sternberg cell. This produces a protein called as CMIP. This protein, what it does is, it goes and attaches itself to the podocyte and inhibits phosphorylation of nephrin. So once this inhibits phosphorylation of nephrin, what happens? Podocyte is going to be unstable. So once podocyte is going to be unstable, it is going to get effaced and there is going to be minimal change disease. Okay. So this is what happens in Hodgkin's disease. The second condition is mycosis fungoides and third is CLL. In CLL, it is important to see that it is more commonly MPGN rather than other diseases. So this is about the etiology of minimal change disease. Now coming to the pathogenesis. Pathogenesis is mainly, this is a T cell mediated disease. It is not a B cell mediated disease. How do we know that it's a T cell mediated disease? One thing is, there are no antibodies detected that can be found against minimal change disease or podocyte antigens in this condition. Second thing is that there are multiple cytokines which are considered to be acting, which causes this disease. Third cause that tells us that this is a T cell mediated mechanism is its excellent response to corticosteroids. It has very good response to corticosteroids. So this also shows that this could be a T cell mediated mechanism. The fourth interesting parameters that was found is when children develop measles and during their recovery, what happened was it was noticed that patients with minimal change disease and measles who went on to recover from measles also recovered from minimal change disease. So during recovery from measles, it is seen that the T cell immunity is suppressed. So this led to recovery from minimal change disease also, indirectly showing us that the T cell immunity is important in minimal change disease. So it is told that the circulating factors are important in causing this disease. So the circulating factors are cytokines, which are interleukin 8 and interleukin 13. So, but however, this interleukin 8 and interleukin 13, the mechanism of how it causes minimal change disease is not very well established. So this is not taken much into consideration. The second circulating factor was hemopexin. This hemopexin is synthesized in the liver and it is known to go to the glomerular basement membrane and attack the heparin sulfate and hence cause proteinuria. But however, it was seen that whenever they took this hemopexin and injected it in rat, it did not cause selective proteinuria. Selective proteinuria means in minimal change disease that we see proteinuria is selective, that only albumin is excreted. So this was not seen. So because of this, hemopexin theory also is not very highly regarded. The third theory is microbial products. So to explain this, let me come to this picture. So here you see that there are microbial products. When these microbial products come and bind to TLR3 and TLR4, it increases something called as CD80. Okay. Now what this CD80 does? It goes and binds and inhibits the phosphorylation of nephrin. Here you can see this is nephrin. CD80 is acting here and it inhibits the phosphorylation of nephrin. So this comes again to the same mechanism where phosphorylation of nephrin is inhibited. Nephrin cannot form a good bond and this podocyte, whatever interdigitation is happening, which maintains this space, so that is lost. So this podocyte is going to collapse. This collapse will happen leading to effacement. Okay, so this is another theory that is considered. So this is about microbial products. And another thing that shows us that microbial products is very important is the fact that whenever a child gets a URI because of a viral infection or a bacterial infection, it is seen that they go back into relapse, right? So this shows that microbial products also can cause this disease. Now next coming to mechanism of proteinuria. So first mechanism is, if you can see, this is the glomerular basement membrane which has proteoglycans, which is mostly heparin sulfate. So when this anionic charge is lost because of any condition, then it can cause proteinuria. Second thing is podocyte dysfunction. So podocyte dysfunction is by the CD80. What happens is podocyte acts like a antigen presenting cell, like a dendritic cell, when it is exposed to microbial products in this disease, and it will secrete this CD80. Now what happens is when there is viral infection, there is stimulation of this TLR3 podocyte receptor, which I showed you, which is this one. You can see the microbial product is coming and acting on the TLR3, and this leads to overexpression of CD80, which we showed. And generally when CD80 is overexpressed, the CTLA4 comes and controls it. But here there is inadequate CTLA4 response. So this leads to interference with phosphorylation of nephrin, which affects the barrier. Okay, so this is a pretty simple mechanism. CD80 increase in the urine is an important biomarker in minimal change disease. However, though it was found that both in FSGS and in MCD CD80 was increased, the correlation was found to be significant in minimal change disease only. So urinary CD80 is increased in patients with minimal change disease. Okay, this is important for you to remember. The second is that angiopoietin-like 4 overexpression is there. What happens is here you can see angiopoietin like 4 molecule which is coming into the glomerular basement membrane, and it is going and binding to the heparin sulfate proteoglycans, which causes the negative charge, and hence it is causing loss of this negative charge. So the negatively charged proteins are easily filtered across the glomerular basement membrane. So this is how proteinuria happens in this condition. Now coming to the pathology of this condition, like I told, light microscopy almost normal. However, you can find subtle changes. So why I'm telling you what these subtle changes are, if there's a question which says a child comes with nephrotic syndrome, has some subtle changes in light microscopy, I don't want you to go under the impression that if light microscopy some change is there, then there's no chance this is minimal change disease. Definitely some subtle changes can be there in few patients. The subtle changes are slight increase in the mesangial matrix and hypercellularity. So whenever you're seeing the light microscopy as a picture, what are the entities that you have to see? You have to see the glomerulus. In the glomerulus, you have to see the mesangium, the endothelium, and the podocytes, what is happening. And then you come outside, you see the tubules, you see the interstitium, and you see the blood vessels. So these are the entities in which you have to see. So first of all, coming to the mesangium, there can be slight increase in the mesangial matrix and hypercellularity. And there can be a global glomerulosclerosis which is less than 10%. You have to note that this is global and it is not segmental. Segmental glomerulosclerosis goes to FSGS. This is global glomerulosclerosis. If you find segmental glomerulosclerosis in your biopsy, then the diagnosis automatically becomes FSGS. It does not become minimal change disease. Okay. This is seen in less than 10% of patients. This can be an age-related change. With age, everyone has this process of undergoing glomerulosclerosis, so it can be age-related. Minor IFTA. IFTA is nothing but interstitial fibrosis and tubular atrophy. Interstitial fibrosis and tubular atrophy. Okay. So this shows that the change or the damage is chronic. It is not anything acute. Next is there can be fat and hyaline droplets in the proximal tubule. So proximal tubule is trying to reabsorb everything that is getting filtered. So protein is getting filtered, fats are getting filtered. All these things is going to be reabsorbed in the proximal tubule and it is going to show fat and hyaline droplets. Okay. Now in immunofluorescence, you can find sometimes, rarely, IgM and C1q. Otherwise, it's going to be negative staining for everything. Sometimes you can find IgM and C1q. So what is the significance of finding IgM and C1q? In IgM nephropathy, what happens is the patient will have increased proteinuria and poor prognosis. That is, response to steroid is going to be lesser. Similar thing happens in C1q nephropathy also. There is going to be poor prognosis. So once these two staining comes in a patient suspecting minimal change disease, we have to be careful. We have to know that the response may not be adequate. Okay. Now coming to electron microscopy. In the electron microscopy, here this is a normal electron microscopy. Here you can see that the podocyte is nicely sitting on the GBM. And there is nice space. Okay. Here you can see this is minimal change disease. This is a podocyte. It is effaced. That is, it has become thinned out and flat. And there is not much space interdigitation that is happening. So this is what happens in electron microscopy of minimal change disease. Now coming to the clinical features of minimal change disease. The most important feature is edema. It is important to note that only after 5 to 7% of body weight increase happens, edema comes out. Edema is more in the leg and in the periorbital region. So what happens in patients having heart failure, they cannot lie down, right, because they have orthopnea. So edema collects more so in the downward area. But in renal issues, that problem is not there. The patient can sleep. So when they sleep and they wake up in the morning, all the collection is going to happen in the face. So that is why you ask for periorbital puffiness early in the morning in these patients. The edema cannot just be in the legs or in the face or in the peritoneum causing ascites, but it can happen in the bowel also. When it happens in the bowel, patient can present with diarrhea. The blood pressure mostly is normal or low normal in this condition, but it can be elevated in some situation where in relapse, in the acute situation, what is going to happen? There's going to be so much volume depletion that the renin-angiotensin activation will happen, leading to hypertension. But once we infuse albumin, we restore the volume of the patient, this hypertension settles. Another condition in which hypertension occurs is when the child has renal vein thrombosis or the patient develops renal vein thrombosis. So in this situation also, hypertension can occur. Abdominal pain and nausea can happen if there is bowel edema. Another important finding is Muircase line. Muircase line is a white band. If you go back to the chapter of approach to nephrotic syndrome, you will find all these things even in detail. So this Muircase line is a transient white band that is seen in the nail of a child with nephrotic syndrome or adult with nephrotic syndrome. And this indicates that at that phase there is relapse or there was hypoalbuminemia at that phase. Other is there can be xanthoma or xanthelasma because of hyperlipidemia. Next is macroscopic hematuria. Macroscopic hematuria is a rare event in nephrotic syndrome. So in minimal change disease, if macroscopic hematuria is occurring, we have to suspect renal vein thrombosis. Now coming to the laboratory findings. We know that nephrotic syndrome or minimal change disease has a pentad which is most important. So what comes in this pentad? First thing is proteinuria. So that is what offsets rest of the 4 things that is there in the pentad. Now what is specific about this proteinuria? This proteinuria is selective, that there is loss of albumin. Okay. To call it nephrotic range in adults, it should be more than 3.5 gram in 24 hours. But whereas in children it can be 50 milligram per kg per 24 hours or it can be 40 milligram per hour per meter square. So here you can see for 24 hours, here per hour is done because in children 24-hour calculation is not going to be easy. So for per hour you can calculate the proteinuria, then you can use this, or 200 milligram protein per millimole of creatinine. So these are the things that can be used in children. They definitely don't ask these numericals. They generally in INSS they have not asked till now, but not to have any surprise, I am explaining all these things. Again, when we come to the natural history of the disease and when I discuss in detail about management of nephrotic syndrome, including minimal change and FSGS, I will be repeating all these things. Okay. Next is urine routine. Urine routine will show a 3+ proteinuria or above when in nephrotic state, and there can be hyaline cast and there can be fat globules. Okay. So once proteinuria happens, what happens? That is albuminuria is happening. The next step is hypoalbuminemia. That is all the albumin is lost in urine. So what happens to the serum albumin? Serum albumin reduces, hypoalbuminemia. Okay. Third thing is edema. So when this happens, edema in nephrotic syndrome, again I will be discussing in approach to nephrotic syndrome. So when edema happens in nephrotic syndrome, what happens is there is going to be loss of protein which leads to reduced oncotic pressure and then edema happens. Next is hyperlipidemia. Hyperlipidemia happens because there is loss of the enzymes required for catabolism of lipids like lecithin cholesterol acyltransferase, lipoprotein lipase. So initially there will be increase in total cholesterol and LDL, and if the proteinuria is massive, then there will be increase of triglycerides also along with VLDL. And when so much hyperlipidemia happens, what happens? Lipiduria happens. So it's a series of things that you can remember in line. So these constitutes the pentad. Okay. Apart from this, acute kidney injury can happen. This will happen. This also I will be dealing in detail with approach to nephrotic syndrome. You can see that. But generally AK happens in adults more than in children. And more so we have to think of ATN or patient having renal vein thrombosis if AKI happens. If there is persistent AKI, then mostly the reason is not minimal change disease, or the cause of the kidney disease may not be minimal change disease. The next is hyponatremia. Hyponatremia, in this era where we are using the direct ion sensing electrodes, it is not seen. The hyponatremia seen is pseudo-hyponatremia because of hyperlipidemia. Okay, so earlier when there was indirect ion sensing electrodes which depended on serum osmolality to get to serum sodium, that time it caused a problem, but as of now we are able to detect serum sodium with a direct ion sensing electrode. So this pseudo hyponatremia problem is getting avoided. Total calcium and vitamin D levels are low. This happens because albumin is low, so total calcium level is low, and vitamin D binding globulin is low, so vitamin D levels are low. When we detect it, doesn't mean actually they are low. The ionized calcium or the vitamin D activity may be all normal. Now coming to the complications, the most important complication is infection. Infection happens because there is low serum immunoglobulin G and there is loss of propyridine and factor B. So in urine, so what happens? This leads to infection with capsulated organism like Streptococcus pneumoniae. So what happens that when a child comes with minimal change disease, we should immunize these children so that they don't develop these infections. Okay. The next thing is they can develop hypercoagulability. Again, this is because of loss of anticoagulant factors like protein C, protein S, antithrombin 3. Meanwhile, there is increased generation of coagulation factors. So this combination leads to hypercoagulability. Now, in a child who is coming with nephrotic syndrome, it is not always necessary to do renal biopsy because mostly we know that in 80% of cases it is because of minimal change disease. So there is no need to do because we know the response to steroid is excellent. So we just directly start steroid. But in few cases we do renal biopsy. That is when there is atypical clinical features like if the child is having persistent hypertension, persistent AKI, these children, or in adults, in all cases we do renal biopsy. This specifically about children I am talking. So if there is hypertension, if there is AKI, if the urine is showing any active sediments, so in all these conditions we will have to do renal biopsy. The second is when it becomes steroid resistant nephrotic syndrome. Think a child came to us, we started the child on steroid, but we continued steroid even for 4 weeks, there is no response, then it is an indication for biopsy. Children more than 12 years, once they cross 12 years, we are not sure that this is minimal change disease, it can be FSGS. So in that situation, our treatment approach might change. So that is why it is important to do biopsy when children cross 12 years. Even less than 1 year, it can be genetic cause of nephrotic syndrome and hence biopsy is required along with genetic testing. And in adults, in all adults we have to do because it can be minimal change disease, it can be FSGS, it can be membranous nephropathy, it can be C3 glomerulopathy presenting as nephrotic syndrome, it can be amyloidosis. So the differential diagnosis is plenty. So we do not, and the treatment is also different for all of these conditions. So we do not want to miss a diagnosis and hence we have to do biopsy in all adults presenting with nephrotic syndrome. Okay. Now, coming to the natural history, this part is quite intimidating. It is difficult to remember even now after so many years of nephrology. So, it is not necessary to remember every definition in this, but when you try to understand, the understanding of the disease becomes easier. I'll tell you which is important entrance point of view. So, first is definition of nephrotic syndrome. So, in children, when there is edema, and urinary PCR is more than 2000 milligram by gram or it is more than 200 milligram by millimole. Okay, so this gram of creatinine, when it is converted to millimole, it's approximately 110, 113. So that is how this calculation comes. Okay, or when there is more than 3.5 gram per day proteinuria or 3 plus protein in urine dipstick along with hypoalbuminemia. Okay, so this we know, more than 3.5 gram per day proteinuria we know. And when it comes to PCR, you take it as 2000 milligram by gram. Okay. When protein is less than 2.5. That is nephrotic syndrome. What is complete remission? When urinary PCR is less than 200 milligram by gram. Okay. Or less than 1 plus of protein on urine dipstick. So from 2000 it has to come down to 200, less than 200. And protein in urine dipstick should be 1 plus. There it can be 3 plus, here it should be 1 plus. And for children, this should be there on 3 consecutive days. That is, you keep measuring on 3 consecutive days, then it can be 1 plus. Then reduction of proteinuria to less than 0.2 gram per day, that is less than 200 milligram per day. And serum albumin more than 3.5 in adults. So in adults, seeing albumin is also important. So serum albumin when it crosses more than 3.5 and proteinuria less than 200 milligram. Okay, this is complete remission. So you know partial remission comes in between this. That is, in children UPCR becomes between 200 to 2000 because we told more than 2000 is nephrotic syndrome. Less than 200 became complete remission. So 200 to 2000 becomes partial remission, or when there is reduction of 50% of proteinuria or greater from the baseline. Okay. In adults, proteinuria between 200 gram and 3.5 gram, that is considered as partial remission, or decrease in proteinuria which is more than 50% from the baseline. Okay. No remission is there is no reduction in proteinuria, it's more than 2000, or the proteinuria remains more than 50% above the baseline. So all this is the thing. Now initial responder or someone who is sensitive, that is when we start therapy, if they achieve remission within 4 weeks of steroid therapy, it is called as initial responder. Next is initial non-responder or steroid resistance. This is very important. This you have to remember. So in children it is 8 weeks. In adults it is 16 weeks. Okay. So this thing is slightly different in the KDIGO guidelines. Here it is slightly different. This is from the FIHALI textbook I have taken. But finally I think in the exam whatever is in the guidelines that can be followed because that will be the latest version. So if you are following the textbook, understand that in the guidelines it can be different, in this it can be different. So this 8 weeks and 16 weeks should be taken. Next is relapse. Relapse is when urinary protein creatinine ratio is again more than 2000 milligram by gram or more than 3 plus protein on urine dipstick for 3 days. Okay. And proteinuria more than 3.5 gram per day occurring after complete remission obtained for more than 1 month. That is, you start on steroids and then you finish the therapy, and then for more than 1 month the patient is disease free. Then the patient develops the disease. It is called as relapse. Infrequent relapse. This is again important. So the important definitions are steroid resistance, infrequent relapse, frequent relapse, and steroid dependence. So these 4 are the important definitions that you have to remember among all these. So infrequent relapse is 1 relapse within 6 months of the initial response or 1 to 3 relapses in any 12-month period. So in 6 months it can be 1 relapse, and in 12 months it can be 1 to 3. This is infrequent relapse. Okay. What comes in frequent relapse? That is 2 or more relapses within 6 months of initial response. That is 2 or more. Okay. So 1 becomes infrequent, 2 or more becomes frequent. Similarly, at 12 months it is going to be 4 or more relapses. Okay. In a 12-month period. So I think this table, if you see, it's pretty easy. So infrequent relapse at 6 months is 1 and at 12 months is 1 to 3. Frequent relapse at 6 months is 2 and at 12 months it is 4 or more. Okay. Steroid dependence. Steroid dependence is 2 consecutive relapses during steroid therapy. That is, steroid you give to the patient goes into remission. Then while you start tapering the dose, again the patient develops relapse. Then you increase their dose, then again they go into remission. Then again when you start tapering, again they develop relapse. So when this happens for 2 times, 2 or more consecutive times, then you call it steroid dependence. Okay. Or also within 14 days of completing the therapy, that is, they go into remission after you start the steroid therapy, and you finish the steroid therapy, finish the treatment, take them off steroid, within 2 weeks if they develop relapse, then it is called as steroid dependence. So steroid dependence has two definitions. One is if they are developing relapse with 2 or more consecutive times while tapering steroid. Second thing is if they are developing within 2 weeks of stopping the steroid therapy. Okay. Now other one is late non-responder. What is a late non-responder? Persistent proteinuria that occurs for more than 4 weeks of steroid therapy after achieving one or more remissions previously. That is, previously when you gave steroid, they achieved remission in 4 weeks. But this time, even after crossing 4 weeks, they are not achieving any remission. So this is called as late non-responder. Now coming to the treatment, see this in this slide, I just want to tell you the approach to treatment in minimal change disease, because the KDIGO guidelines for treatment I will be dealing with in detail in the coming sessions after finishing FSGS. So this is just the approach. Okay. So here you see when a child is having biopsy proven or suspected minimal change disease, the first thing we do is steroid therapy. Like I told, no indication for biopsy, nothing, just give steroid therapy. Okay. The dose and everything, duration, I'll tell while I'm discussing the guidelines, KDIGO guidelines. Okay. So 95% of children respond to steroid. That is a beautiful thing that we see. The moment we start steroid, within 1 week, 95% of children within 1 week become dry and lose their edema, proteinuria stops. So 95%. Okay. After this, what happens? No relapse is seen in 25% only. So among the children, 95% achieve remission, but only 25% stay without relapsing. 75% are going to relapse, and in that 75% also 50% are frequently relapsing and only 25% are infrequently relapsing. So majority of children, that is 50% of children, go into frequently relapsing. Okay. Now once they are no relapsing, there's nothing to do. If they're infrequently relapsing, you see if there is any sign of steroid toxicity. If there is no sign of steroid toxicity, then go ahead with steroid therapy, because you know that they have responded to steroid, you give them another course of steroid. Even then, if there is continuing relapses, that is they switch to the frequently relapsing type, then consider corticosteroid sparing therapy. What is this? I'll come to it. Okay. So this is the management of infrequently relapsing nephrotic syndrome, because this might happen once a year, twice a year. So in this situation, you don't have to worry about steroid toxicity. You just give them steroid, they respond, and then you can let it go. Only if they develop signs of steroid toxicity, then you are going to think about corticosteroid sparing therapy. Now coming to frequent relapser. Okay, among frequent relapses, there are two types. One is frequent relapser, one is, sorry, this is not development, this is steroid dependent. Okay. So they can be frequent relapses or they can be steroid dependent. Why it is important for you to mug up that definition of what is a frequent relapser, what is a steroid dependent? Because we classify like this because the therapy varies in this. For frequently relapsing, cyclophosphamide is very, very important, and cyclophosphamide shows more response in frequently relapsing nephrotic syndrome than in steroid dependent nephrotic syndrome. This is very, very important. So a child comes with steroid dependent nephrotic syndrome, first line is CNI, cyclosporin or tacrolimus. But if this happens as frequently relapsing nephrotic syndrome, then we consider cyclophosphamide first. CNI can be tried, but cyclophosphamide has good response. Okay. So you give that, the child goes into remission, fine. If they are still relapsing, then you have to consider third line, that is rituximab or MMF. Okay. So the thing is that rituximab or MMF, all these are experimental therapy. Research is going on, the evidence is not very strong, but we are not left with much option. So we can think about MMF. So if they are frequently relapsing, that means you cannot keep giving them steroid 4 times, 6 times in a year, and each time it goes on for 1 to 2 months. So you cannot do that. So switch to second line. Second line is cyclophosphamide. Give cyclophosphamide. Even then, if they are relapsing, try CNI. With CNI also they are relapsing, then you have to go to third line, which is rituximab or MMF. What happens in steroid dependent? There is no choice of cyclophosphamide for us. It has very less response. So prefer CNI. If they go into CNI, if they go into remission with CNI, well and good. Once CNI is started, it is to be continued for 1 to 2 years. Okay, 1 to 2 years it will have to be continued. Now, if the child develops CNI dependence, that is after 1.5 years, you're trying to taper, again the child goes into relapse, then consider the third line, which is rituximab or MMF. Another important point that you have to remember is you can give cyclophosphamide only once the child is in remission with steroid. Otherwise, there is high chance of bladder toxicity that can develop. So, only once the child is in remission, you can introduce cyclophosphamide. If the child is in full-blown relapse, give steroid. You know that the child responds to steroid. So, make them attain remission and then put this therapy. Okay. So, this is about the 95% of population. What happens to 5%? This 5% are non-responders. So, if biopsy is not already done, do that and do genetic testing, because like I said, genetic etiologies mostly can be FSGS and they might not respond. Okay. So, next is you can give them cyclosporin or tacrolimus. In this situation, this is the first line choice, that is in steroid resistant nephrotic syndrome. CNI is considered first. Similarly, just revising, in steroid dependent nephrotic syndrome, again CNI. In frequently relapsing nephrotic syndrome, it is cyclophosphamide. Okay. So, they go into remission, and then if you see CNI dependency or toxicity or no response, then you can only consider symptomatic therapy. There is nothing else that is proven to work. Rituximab is tried, multiple other drugs are tried, but nothing works much. So, we go for symptomatic therapy. We give them ACE inhibitors, ARBs to reduce the proteinuria. So, this is about children. You understood, no? There are 95% of children respond, 5% don't respond. Among this 95% responders, 25% don't relapse, 25% are infrequent relapses, 50% are frequent relapses and steroid dependent. So, in this 25% of infrequent relapse, we give steroid therapy only. We are not worried because there won't be any steroid toxicity. In the 50% among the frequently relapsing, we consider cyclophosphamide. Among steroid dependent, we consider CNI. Again, if they are steroid resistant, we are going to consider CNI. So, this is the outline of treatment. Okay. So, next coming to adult. Adult, of course, we will do biopsy. So, they are going to be biopsy proven. So, you consider steroid therapy for 4 to 16 weeks. Okay. Generally, you have to give for 4 months before labeling them as steroid resistant. So, if they go into remission, very good. They can go into sustained remission. They can become steroid dependent. They can become infrequent relapses and they can become frequent relapses. Again, steroid dependent, we know that we can either try cyclophosphamide or CNI. Infrequent relapses, again you repeat steroid therapy like in children. Frequent relapses can try cyclophosphamide. So, in steroid dependent, we consider CNI. In infrequent relapses, we again go for steroid therapy. In frequent relapses, we consider cyclophosphamide, only one course to be given, and next is cyclosporin or tacrolimus. This only one course because you don't want to cause any gonadal toxicity, you don't want to cause any malignancy. So, that is why. Okay, so once you do this, if there is no response or there is toxicity or CNI dependency, then you can consider rituximab or MMF. This is the third line therapy. Okay. Similarly, in adult, if there is contraindication to steroid or if there is steroid resistance, then again we can consider CNI therapy. Okay, so this is how we manage minimal change disease in children and in adult. Now, the detail of the dosing, the duration and the latest whatever literature is there about this, I'll discuss this in Approach to Treatment for Nephrotic Syndrome, where I'll be discussing detail about KDIGO guidelines. So, in this I want you to get a idea of how we treat, at least remember the names, what we are giving. Then all the details I'll cover in that section. Okay, so you can refer that section. So, thank you friends. I hope you have understood about minimal change disease. Meet you in the next class.